Well, in my case, we're going to start with the diagnostic classification criteria of the disease. First, a brief introduction to rheumatoid arthritis to give us some context. As you know, it is a chronic inflammatory autoimmune disease that is classically identified by symmetrical involvement of the small and medium joints. However, we must not forget that it can also present extra-articular manifestations, which will worsen the prognosis for our patients. For example, pulmonary involvement such as ILD, cutaneous involvement with rheumatoid nodules, ocular involvement with scleritis, and many others. The prevalence is estimated to be between 0.5% and 1%, being higher in Northern European countries. In turn, it has been observed that it has a higher incidence in women than in men, with a peak between 50 and 60 years of age. And in those patients who are not well treated and have a more uncontrolled disease, there is a high rate of disability and decreased quality of life, something we must take into account in our patients. In this slide, I wanted to give us a bit of context and present the progression of the disease as we traditionally understand it, which can be divided into 6 phases. First, as is usually the case in all the inflammatory diseases we treat, we have an individual who is genetically predisposed, highlighting the association with HLA-DRB1, in whom, at a certain point, environmental triggering factors occur, with smoking being particularly notable in the case of rheumatoid arthritis. This will trigger an autoimmune response in the human body, activating the inflammatory cascade that will begin to cause the damage we recognize as rheumatoid arthritis. That said, we would move into the last 3 phases of the disease. Phase D, where symptoms begin to appear. An initial phase D, where patients will report experiencing arthralgia, but objectively, we will not yet observe synovitis or joint inflammation. Then we move into a 5th phase, phase E, an undifferentiated arthritis phase, where we can indeed objectively detect this inflammation, this synovitis. However, it will not fully meet the criteria that would be fulfilled in the final phase, phase F of rheumatoid arthritis, which, as we will see later, is really the stage we aim to diagnose before reaching, because that way we can spare our patient the long-term consequences of the disease. As an introduction, now delving a bit more into the diagnostic aspect, it's important to mention that the diagnosis of rheumatoid arthritis is fundamentally clinical and must be made by a rheumatology specialist who will primarily rely on a medical history and physical examination, which my colleague Pablo will later discuss and explore in more detail, and will also rely initially on blood tests with a basic profile, including complete blood count and biochemistry, incorporating acute phase reactants, as we will see later, as well as the autoimmunity profile with rheumatoid factor and anti-CCP antibodies. We will also rely on imaging tests, primarily an X-ray for sure, and we can also use other tools such as ultrasound or more advanced ones like MRI or CT scan. And with that said, we now delve deeper into the diagnostic classification criteria, which currently are the 2010 ACR-EULAR criteria. These criteria are an update from the previous ones we had, which were the 1987 ACR criteria. Until then, they had not been updated. The 1987 criteria had very good sensitivity and specificity when it came to diagnosing an already established rheumatoid arthritis, that phase F we mentioned earlier. However, it has been observed that by then we are already diagnosing too late, since even in those criteria, radiographic changes were being scored. And this is something we want to avoid, reaching a diagnosis so late in our patients, as it will lead to lasting consequences for them. In this context, the 2010 ACR-EULAR criteria emerged, introducing a new approach that places greater emphasis on early diagnosis to initiate treatment and prevent these consequences. And these are criteria that will increase sensitivity in the earliest stages of the disease, aiming to intervene when synovitis is present, even if the full criteria are not yet met, in order to prevent lasting damage to the patient. And it's important to highlight that these are classification criteria, not diagnostic ones, which is something that was already mentioned several times yesterday. And what does this mean? Because these are criteria designed to standardize the clinical characteristics of our patients when they are being enrolled and included in clinical trials. Nevertheless, we can rely on them when establishing a diagnosis, but ultimately, the diagnosis and diagnostic decision will always be clinical and made by the rheumatology specialist. And here we have the 2010 criteria. The target population, that is the starting point, is that our patient must present with at least one joint with clinical synovitis. In other words, we must be able to confirm during the examination that a joint is inflamed and that this synovitis cannot be explained by another disease. Then, as you can see, these are criteria based on a scoring system. The maximum score that can be reached is 10 points, and we would classify it as rheumatoid arthritis starting from 6 points. To simplify them a bit, although these criteria are already quite straightforward, we can say that the specialist clinician applying them mainly relies on 2 things. On one hand, the medical history and physical examination, since the duration of symptoms is scored. From 6 weeks onward, we would assign 1 point. And also joint involvement. Because as you can see, and logically so, the more joints affected, the higher the score, and especially if the affected joints are smaller, you score even more. According to the criteria, the joints considered large are the ones marked in blue, and those considered small are the ones marked in orange, which are basically the ones you would typically think of as small. with the exception of the distal interphalangeal joints and the first metacarpophalangeal and metatarsophalangeal joints. On the other hand, in addition to the medical history and physical examination, the criteria are based on a blood test where we will request acute phase reactants, ESR and CRP initially, which will score points if they are elevated, as well as serological criteria involving the rheumatoid factor and anti-CCP. These will score points if they are positive, with higher scores if they are positive at high titers. Well, as we've seen, these criteria are based on a foundation where inflammation, eosinovitis, is already objectively identified. But what about those patients in that earlier phase we mentioned, where there are arthralgias but no objective signs of inflammation? Well, in 2016, EULAR published this definition of arthralgia suspected of progressing to rheumatoid arthritis and outlined 7 criteria to take into account, and that we should be more aware of in consultations and keep a closer eye on patients who present with them, since they are at higher risk of progressing to rheumatoid arthritis. And these criteria, or rather these characteristics, include the presence of joint symptoms of recent onset with less than 1 year of progression, symptoms located in the metacarpophalangeal joints, symptoms being more severe in the early morning hours, and morning stiffness lasting more than 1 hour, and the presence of a first-degree family history of rheumatoid arthritis in the patient. In turn, difficulty in making a fist and a positive squeeze test would also be scored.